Hi, everyone, and welcome to our virtual health event with UCHealth. My name is Hannah Strepfer, and I'm the Senior Event Coordinator here with the Highlands Ranch Community Association. We are so excited that you took your time out of the evening tonight to discuss women's health. We are grateful for UCHealth Highlands Ranch Hospital as a community partner and happy to host this wonderful event with their assistance. Before we get started, I would like to go over a few housekeeping items. We are recording the webinar this evening, and we will be sending this out via email by the end of the week. During this webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box. This can be found in your control panel, either on the top or bottom of your screen. We will save the Q&A portion towards the end of the event. Our presenter this evening is Dr. Radhika Acharya from UCHealth Highlands Ranch Hospital. She's board certified in both hematology and oncology. Now, without further ado, I'll pass the time off to Dr. Acharya.
Thank you, Hannah. I appreciate you having me. So I'm a medical oncologist at UCHealth Highlands Ranch Hospital in Highlands Ranch, Colorado. So I will get started. So let's see. There we go. So we're going to be looking at common female cancers, and it's going to be sort of interesting because one of the cancers that I am going to highlight is actually lung cancer, and I'll explain why. So this was a pretty broad topic. We're going to look at risks, prevention, and treatment, and there'll definitely be time for questions, which I think would be really important because there was a lot to cover with this topic. So here are some statistics. I'm not going to read every one, but it's really interesting. So 1 out of every 2 men are diagnosed with cancer, while 1 out of every 3 women are diagnosed with cancer. And that's because women actually carry an extra gene that offers some protection from development of cancer. So specifically for head and neck, esophageal, and bladder cancer. There were 287,850 women diagnosed with breast cancer specifically in 2022, and just about half of that were diagnosed with lung cancer. And then 100,000 women diagnosed with other gynecologic cancers such as uterine, ovarian, and cervical cancer. And then colorectal drops to a little bit lower. And we'll see as the presentation goes on, but colorectal cancer is actually on the rise. And it's starting at a younger and younger age. Oops. There we go. And the highest death rates are actually for lung cancer and then followed by colorectal. Of note as well, melanoma is on the rise, and that is obviously because of sun exposure. And what we know about melanoma is that the risk of melanoma really increases based on sun exposure at a young age. So under the age of 18, the sun exposure that occurs during that time is really what increases the risk of melanoma later in life. Lung cancer and ovarian cancer are on the decline. And lung cancer specifically is related to declining smoking rates as well. We have really made a lot of strides in the early diagnoses of cancer as well as the treatments. So again, as you can see here, cancer death rates have actually dropped 27% from 2001 to 2020. So that is a pretty big decline in the death rate from cancer. And that just speaks to how much we've evolved in regards to treatment. Early diagnosis leads to a higher rate of cure. So when we look at the raw numbers, and this is just sort of so you can kind of have an understanding and grasp of how many the numbers are, the absolute numbers. So when we look at lung cancer, 136,000 people died from lung cancer, and less were female. So more people dying from lung cancer are men. And same with colorectal cancer, 51,000 total patients died from colorectal cancer, and the numbers tend to be higher in males than females. Same with pancreas cancer, and obviously breast cancer. Only 1% of breast cancer diagnoses are male breast cancers. And so that obviously that number is going to be higher for females. And then 37,000 males died of prostate cancer. And then liver cancers and liver disease is also on the rise in this country especially. When we look at lung cancer, which is actually pretty common in women, it was one of the highest cancers in women. Smoking is obviously the #1 cause, and that it accounts for approximately 90% of all lung cancers. The risk reduction varies from 20 to 90% as you quit smoking, and the reduction becomes evident within 5 years of stopping smoking, with a progressive decline after that. Former smokers who have been abstinent for more than 14 years had an 80 to 90% reduction in their risk of lung cancer compared to current smokers, but the lung cancer risk does remain higher than in a never smoker. So unfortunately, we never quite go back down to the normal risk once you've smoked, but you have the opportunity to really decrease your risk pretty significantly. There's really a lot of push these days for lung cancer screening. We realize that screening for lung cancer leads to an earlier diagnosis, which ultimately leads to a higher cure rate. So there are certain criteria that for lung cancer screening, and you can review that with your primary care physician, but it has to do with how many years you have smoked, how many years since you have smoked, and other risk factors. But it is a low dose screening CAT scan without contrast, so not a chest x-ray, but rather a CT scan, again, low dose. No contrast is given, and that has been shown to really find small tumors that can be treated very quickly and typically with surgery rather than additional therapy. Obviously, there's always downsides to any screening modalities, and you can always detect abnormalities on a CT scan that require further evaluation, but they are actually benign, right? So doing a screening test can show something that's actually benign, but it requires you to have an invasive procedure to prove it, and it can obviously create increased anxiety as well. So we can see here, these are the criteria you may qualify. These are Medicare guidelines and USPSTF recommendations as well. But you can see current or former smoker who has quit within 15 years, between the ages of 50 to 77 or 50 to 80, and have a 20 pack year smoking history. And the way we define pack year history is based on the amount that you are smoking times the number of years the number of packs you're smoking per day times the number of years you've been smoking. And so this has really changed lung cancer in terms of earlier diagnoses and better cure rates. Now we're going to turn to breast cancer in terms of screening, and then I'll come back and talk about prevention as well as treatment of lung cancer. But something I want to really stress here is that in terms of screening guidelines and recommendations, we can see that there are several different organizations, and they all have slightly different screening recommendations. And this makes it very challenging to practice medicine and for people to really understand what the recommendations are. So you can kind of look at this to get a guideline, but so much of it depends upon your specific risk. And so looking at the risks, we can see that increasing age is definitely a risk. We also know that if you have your menstrual cycle starting earlier in life and have a late onset of menopause, that is also a risk. Family history is a risk. Genetics are a risk. Dense breast tissue is a risk, and we'll have a slide looking at some of those. But just sort of realizing that you need to speak to your doctor and really understand what the guidelines are and what fits you the best. Don't just take a standard blanket recommendation, really speak to your doctor. And so this slide sort of represents that obviously with increasing age, the percentage of developing breast cancer goes up. And it is a disease typically of menopausal or postmenopausal women. So here are some additional risk factors. We know that obesity, BMI greater than 30 specifically in postmenopausal women, does really increase the risk of breast cancer. It's interesting, and we don't really know the reason, but having that same level of obesity in a premenopausal woman does not seem to increase your risk of developing breast cancer. We know that estrogen lies within the adipose tissue or the fatty tissue, and that estrogen can sort of feed the cancer, especially estrogen positive breast cancers. We know that insulin resistance increases risk of breast cancer. And we know that there's about an 89% increased risk with a higher BMI as compared to a lower BMI. So being conscious of that is really, really important. We also know that birth control pills can also increase risk of breast cancer. This is temporary. Once you stop, the risk does return back to normal after 2 to 5 years. OCPs are actually very protective for ovarian cancer, so this can be a tricky to balance. But again, talking to your doctor and talking through what your risks are really, really important. We know that when women have a higher breast density, so on your mammogram report, it does state your breast density. If it says heterogeneously dense breast tissue or extremely dense breast tissue, we know that the percentage likelihood is increased that you could develop breast cancer. And so sometimes we supplement the screening test with an ultrasound, a whole breast ultrasound, sometimes MRIs of the breast as well, depending upon your other risk factors. But again, pay attention to what's written at the bottom of your mammogram report and talk to your doctor about supplementing the mammogram with other modalities if you have elevated or increased breast tissue. Mammograms do not work very well, or as well, I should say, on patients who have higher breast density. Interestingly, that bone density also plays a part. It's counterintuitive to what you would think. Bone density that is improved or higher bone density is actually linked to an increased risk of breast cancer. And the thought is that it has to do with estrogen, because if you have the higher bone density, it's probably because you have more estrogen or have been in the premenopausal state for more years. And that is an increased risk. Some controversial risk factors are phthalates, which we see as chemicals in certain cosmetics and shampoos. Night shift work has also been linked to a higher risk of just overall cancer in general. Infertility has been sort of subject to some debate, but it has not really been proven. And same with things like deodorant, the aluminum in deodorant. I think you can find some studies, they're not so well designed, so it hasn't been proven per se. So we have modifiable risk factors. What are the things that we can do in our lives to decrease our risk really of cancer overall? This part may be more specific to breast cancer, but really it's overall. So we know that a high fiber diet is really important. 30 to 40 grams of fiber a day really does reduce your risk of most cancers, but specifically colorectal and breast cancer. Reducing alcohol, this is always the tough one, but it's really interesting data. There is a 10% increased risk with each 10 grams of alcohol per day. So basically, with every additional drink, there's a 10% increase in risk of breast cancer specifically. And so breast cancer was also linearly correlated with a cumulative lifetime alcohol intake. And again, interestingly, we see that the strongest risk is associated with early drinking, right, before the age of 25, and then later adult life, which is awful for us because a lot of, we're in college before age 25. So just trying to reduce your risk of drinking at this time is still going to be helpful. There was a recent study that came out of Canada confirming that 3 drinks per week increases the risk of 7 cancers. So trying to keep the alcohol to less than 2 drinks per week is usually considered now moderate drinking and does have a risk reduction associated. Obviously, we don't want anyone smoking, and then physical exercise also decreases your risk of recurrent cancer or just cancer initially as well. And that is typically defined as 5 days of exercise, 30 minutes a day, in addition to 2 to 3 days of weight-bearing exercises or activity. Okay, so back to alcohol, just one more slide on that, just for definitions. So moderate drinking or low risk for alcohol problems is females who drink less than or 1 drink per day, or really less than 3 drinks on any single day. I mean, there's all these sort of definitions. And then heavy drinking is greater than 3 drinks per day or greater than 7 drinks per week. for females. And then binge drinking is defined as greater than or equal to 4 drinks in one drinking session. So again, to kind of remind you in terms of the data, it's really looking at less than 3 drinks per week to really have that risk reduction. So now looking at cervical cancer, screening and prevention, there again are so many guidelines based on age, risk factors, and which organization is putting out the guidelines in regards to screening. So you kind of have heard me say this a few different times, but really speaking to your primary care doctor, to speaking to your gynecologist to understand the frequency and the method of screening that is best for you is really, really important, because we know that HPV is linked to multiple cancers, cervical, head, neck, and anal, and they're hard to treat cancers. So prevention is the key. And at early stages, these are highly curable cancers. So really sort of thinking through your risk factors, being screened, considering the HPV vaccines as a method of prevention is really paramount, because again, I can't stress enough how preventable these HPV related cancers are. And HPV is a high prevalence, has a high prevalence of transmission. Risk factors, again, so there's a couple of different kinds of cervical cancer. So HPV positive, there's multiple strains that are related more towards cancer. We know that smoking also increases your risk, specifically of squamous cell cervical cancer. Having multiple sexual partners increases your risk. Using birth control is obviously really important if that's what you're desiring, but using a condom for barrier protection is really, really important. Also remembering that oral sex can also increase your risk of cervical cancer because of transmission. Early age of intercourse before the age of 21 also has a 1.5-fold increased risk of the development of cervical cancer. Obviously, having a high-risk sexual partner, being immunocompromised, patients who have HIV also have an increased risk of cervical cancer. And then interestingly, having a non-circumcised partner can also increase your risk. So these are just things to think about, but really being screened appropriately is the most important thing. So now we're back to lung cancer, thinking about the treatment. And this is, again, such a complex issue, and it really depends on the stage of the cancer. So much progress has really been made. Patients with lung cancer are living longer and longer. I have a patient who was diagnosed, I think, in 2001 with metastatic lung cancer. And so it's been 22 years, and it's amazing. So I think that, we have so many different modalities of treatment that can really give lifelong, well, I shouldn't say lifelong because it's not technically curable, but really long-term remissions that we didn't expect previously. Again, early detection is always the key. So to thinking about your risk factors and thinking about whether you would benefit from a screening CAT scan. All lung cancer should have molecular testing. We actually send the tumor tissue to a lab, and they look for certain targets on the cancer cell that we can then utilize for treatment. So that has been a really important factor in the improvement of treatment with lung cancer. We check something called a PD-L1, which is a ligand or a protein that is on the cancer cell, and that helps define which patients may be eligible for immunotherapy. And that also kind of tells us that the immunotherapy may be more effective actually than chemotherapy. So immunotherapy sort of is an infusion that primes the immune system so it sees the cancer cells or recognizes the cancer cell as foreign. Because what happens in cancer is that your immune system is not really working as well as it should. So you start to make these abnormal cells that your immune system does not recognize. And so then they're allowed to continue to grow. So if you have an immune system that is more functional, it will catch these cancer cells before they can proliferate or grow or divide to the point of a tumor, and it can correct the abnormality within the cell. So the immunotherapy heightens the immune system so it can recognize the cancer as foreign and attack the cancer. And that has also revolutionized therapy and treatment within multiple different cancers, specifically lung cancer, melanoma, renal cell cancers, breast cancers, so multiple bladder cancer. So we're really seeing a huge improvement with these medications. The treatment, as always with any of these cancers, always depends on the stage. If it's really small and early, surgery may be enough. If it's larger, then sometimes surgery followed by chemotherapy or surgery followed by radiation therapy. And obviously, if it has spread far beyond the lung, then we would initiate chemotherapy or targeted therapy or immunotherapy. Again, I've said this a couple of times, but surgery is usually paramount in early stage disease across all cancers. If you can surgically remove it and get clear margins, your outcome and prognosis will be better. Metastatic disease is typically not curable, but certainly much more treatable than it used to be. Treatment of breast cancer, again, same thing, so much progress. We are finding so many targets that we can hit and test for that has really revolutionized and changed the treatment strategies. As always, the treatment depends on the stage and biological factors. So for instance, if you have a small tumor, you can remove it from the breast and sometimes need radiation and sometimes not, based on the size of the tumor and the lymph node evaluation. So we're realizing that we can treat with less and less treatment after surgery, really based on the biological factors. So is the estrogen receptor positive? Is that tumor fed by estrogen? Does it require estrogen to grow? If it does, can we block? How can we block the estrogen in order to starve the cancer cells? We know HER2/neu is a protein or a molecular marker on the cell that says we need to use a medicine called Herceptin, because that is targeted towards that protein, and it will cause what we call apoptosis, or kind of blowing up of that cell. And it will just target those cells specifically with really little toxicity to the normal cells. We know that triple negative breast cancers are obviously tend to be much more aggressive, but we now have markers we can use there as well. And we found that immunotherapy is really helpful when added to chemotherapy in triple negative disease, and we can prolong survival in those patients. So again, it's really changed how we do things. We know that we can assess the biology of the tumor by doing an assay called Oncotype DX, which looks at the genomic sequence within the tumor tissue itself. So you actually send the tumor tissue or the biopsy or the surgical specimen to a lab in California. They look at the genomic sequence and they say, okay, your prognosis, your risk of having a recurrence is, let's say, 10%. Your benefit from chemotherapy is 5%. And this is just an example. Or you don't get any benefit from chemotherapy. And so then we know, okay, we're not going to offer you chemotherapy because it's not going to help you. It's just going to, give you potentially the toxicities. But obviously, in some cases, chemotherapy is very helpful and can really reduce that risk of recurrence dramatically. So we have all of this testing that can sort of, at a very sophisticated level, look at the biology of the tumor. We also have something called breast cancer index testing, BCI testing, which tells us how long do we need to continue with anti-estrogen therapy in those patients who have breast cancer that is estrogen positive. So do they just need 5 years of an anti-estrogen therapy? Do they need 10 years? And if we do 10 years, how much benefit are they actually getting? Are they getting a 1% benefit? Are they getting a 5% benefit? And this way we can really tailor treatments. We can really guide the patients, and we can sort of say, okay, here's the information. What do you want to do? But at least you have the data at your disposal to make some of these decisions. And we are learning that we can really avoid radiation therapy in women who are over the age of 70 with low-risk disease. And this has, again, been really life-changing for so many women, because we're able to bypass radiation and the toxicity of radiation in those patients who will not benefit for it. And we now know the criteria in which setting we can do that. So treatment of cervical cancer, you've heard me say it 1,000 times already tonight, but screening is really important. I think really my focus is starting to move towards prevention, because we just want to really prevent or treat at a really early age. And cervical cancer is very complex to treat. So sometimes we do surgery, sometimes we do radiation and chemotherapy, sometimes we just do chemotherapy. So it really just depends. It's a pretty complex treatment algorithm. Again, very much dependent upon stage. Patterns of metastases. How can these tumors spread? So cervical, lung cancer, and breast cancer are the three that we sort of looked at. They can all metastasize or spread. And I always give this example to my patients, but it can spread via microscopic cells, via the lymphatic system or the lymphatic channels or the bloodstream, and that's called hematogenous spread. So you have the blood supply that flows everywhere in the body. It goes, from obviously through the heart to the lungs, through all the organs, down to your big toe, all of that, right? It's the blood supply is not compartmentalized, it's free flowing. So if there are microscopic cells within the bloodstream or within the lymphatic system, it can spread and move to other parts of the body. And so that's the vehicle and that's the mechanism by which it can spread. So that's why it's so important to sort of say, catch it early, do the treatments that are sort of meant for the biology of the disease, and then monitor very carefully in post-surveillance. We know that bone, lung, liver, and brain, unfortunately, are all common sites of spread. We can do a lot of targeted treatments as well. If there is a single site of disease, we can remove it surgically, we can radiate it, and we can still have long-term control of the disease. Again, molecular testing, I've spoken about it already, but most of the time with most of these cancers, especially in later stage disease, we are sending these tumors for testing. So, you may have heard of Guardant 360, Foundation 1, Caris testing. There's so many different names and different companies, but what they're doing is they are looking for targets. They're looking for alterations within the cancer cell that can be a target for treatment. So HER2/neu is one example. If you have HER2/neu positivity on the cell, we give the medicine Herceptin. If you have PD-L1, we can give immunotherapy. So not only can we give you those treatments, but we know that we have a higher success rate with those treatments if you have those targets. And we oftentimes repeat the testing. So if someone had metastatic disease and they have progression, we would potentially repeat testing on the blood or repeat a biopsy because cancer cells do mutate. And that, and so that means if we see a mutation, we would want to change the treatment to meet that change. Prevention, again, is the key, right? And obviously not all cancer is preventable, but anything we can do to improve our quality of life, to decrease the risk of developing a cancer is what we should try to focus on ahead of time. So obviously no smoking, reducing alcohol intake, and maintaining one's weight are very, very important. And the other thing in terms of exercise is even if you have someone who is very, very lean and thin, but with very little muscle mass, and you have someone that you might think has a little extra weight, but they have more muscle mass, their quality of life and risk will be less. So it's not just your weight as in, on a scale, but it's really your muscle mass. So really maintaining that is really, really important. And even if someone had the diagnosis of cancer, maintaining their muscle mass during treatment will improve their outcome. And so that's just a really important point, that it's not just being thin, it's being lean, muscular, and having that body mass. Eating organic versus not organic, super controversial. I think many people may be familiar with the Dirty Dozen or the Clean 15. There are things you can look up online to see which organic fruits and vegetables tend to be the most important to try to keep organic if you can. And those are things with thinner skin like tomatoes and peppers, lettuce, the green leafies, strawberries. Those things tend to be important. But really, by and large, it hasn't been proven to really show a reduction in cancer risk across multiple studies. I think ultimately we're going to be able to do some genetic testing to sort of see which diet is best for each individual. So coming into diet, an interesting topic. We all get emails every day, do this, do that, intermittent fasting, keto, vegan, vegetarian, Mediterranean. So what are really the facts and what is really best for you? Everyone is different, and that's really what we're learning. We're learning that it's hard to maintain a really strict diet, so it really needs to be a lifestyle. Keto diets are not optimal for everyone. Intermittent fasting, I was reading a really great article, intermittent fasting doesn't work for everyone. And sometimes things work in the beginning and then they stop working. So I think, thinking about what works for you is best and what feels like it's sustainable is best. We do have some facts. We know that reducing, I hate to say avoid, but really reducing red meat is really important. Avoiding processed foods and things like deli meat, really important. Plant-based is really important. It doesn't mean you need to be a vegetarian. I don't know that we really have data on pure vegetarianism being better, but it is definitely saying when you look at your plate, most of your plate has plants and vegetables, small piece of meat, or sometimes vegetarian, and then a little bit of starch. The Mediterranean diet has gotten a lot of publicity, and it's really hard to find what the definition or how to define the Mediterranean diet is. It's typically high in fruits and vegetables, whole grains, beans, nuts, and seeds. Obviously includes a lot of olive oil, which is fat, but good fat. It also does allow for low to moderate wine consumption. Interestingly, based on the data, they shouldn't be having much wine, but it seems to be that I think the other parts of their diet that is so good sort of overcomes that. And we also know that there is some health benefits to wine consumption. It's low to moderate amounts of fish, poultry, and dairy products. And as we stated previously, really includes very little red meat. That red meat gets broken down to these N-nitroso compounds, which are then carcinogenic to the colon specifically. And so that's why red meat and processed meat and really charred meat can really lead to an increased risk of cancer. And then the data is based on these validated studies. We know that the Mediterranean diet also really improves cardiovascular risks as well as risk of stroke. The blue zone diet also has gotten some publicity, very similar to the Mediterranean diet. It's 95% vegetables, fruits, grains, and legumes. Really, again, not eating a whole lot of meat, but it's not zero. Really not having much dairy, sugary foods or drinks, and again, low on the processed foods. So very similar diet. There's a lot of data on the blue zone diet, and there's definitely a decreased risk of cancer in those regions that are following the blue zone diets. So that would be in Acharya, Greece, Loma Linda, California, interestingly, the Nicoya Peninsula, which is the western side of Costa Rica, Okinawa, Japan, and then Sardinia, Italy. Those are considered the 5 blue zones. I just sort of want to end with really the importance of the gut and the gut microbiome. And I could have had probably at least 10 more slides really sort of talking through the data in regards to the microbiome and the gut. We all sort of have heard about probiotics, and there's a million different probiotics out there. How do you know which one to have or use? Does it really work? Does it actually repopulate the gut? And so that's one whole topic, but just sort of really thinking about the gut microbiome and its involvement with everything in our life. I mean, you can find data on prevention of dementia, cancer, immune system. I just saw something on autism, ADHD. It is everywhere. So what we're realizing is that what our gut is made up of, the gut flora, as they say, is really influential in how we live. And having processed foods and alcohol and toxins in the environment, some of which we definitely cannot avoid, that affects the gut microbiome. And so in a negative way. And so we know that antibiotics, for instance, are obviously essential at times, and we have to take them. But when you take an antibiotic, against biotic, which is bacteria, you're also sort of washing out the good gut bacteria. And that can lead to increased risk of certain other types of infections, and it can kind of irritate the gut. One fact I learned is that, obesity can be linked to overuse of antibiotics because it's disrupting the gut microbiome. And so repopulating the gut microbiome with good bacteria is really, really important. And so taking a probiotic with a prebiotic can be very helpful. But really fiber and fermented foods and vegetables and fruits are really how you get it. So if you diversify your diet with multiple diverse, healthy things, you are going to continue to populate your gut microbiome with good bacteria. And then trying to not take antibiotics when you don't need it. Of course, you need it. But sort of thinking through that, or if you are taking an antibiotic, add in a probiotic with it, can be really, really helpful. There was a really nice study that showed the benefit of fiber, and actually in patients who have cancer on immunotherapy, I'm just going to read this, but for every 5-gram increase in daily fiber intake, it corresponded to a 30% improvement in risk reduction of cancer or cancer progression. So those are huge numbers. And again, all really based on the gut microbiome. There was another study that looked at breast tumors in mice, and they injected probiotics in the breast, and it actually caused a regression of the tumor. So just really understanding the gut and its implications in so many parts of our life is really important. So I think that was my last slide. So I hope you guys have some questions, and I'm happy to answer anything.
Thank you, Dr. Acharya. Yes, we'll now go ahead and take some questions. So please make sure to type your questions into our chat box located on either the top or bottom of your screen. And I'll just wait for some questions to come in.
Okay.
Al, I saw your hand raised. Do you have a question?
No, that was an accident.
Okay, no worries. All right, one question for you, Dr. Acharya.
Sure.
This question is, can you talk about the type of exercise you should try and incorporate? I know you mentioned this about 30 minutes or 30 minutes a day.
Yes. Yes, of course. So I think when you look at the guidelines, they talk about, so NCCN, which is the National Cancer Center Network guidelines, they talk about 30 minutes a day for 5 days a week, so 150 minutes a week with 2 to 3 days of weight-bearing exercises as well. But, honestly, anything is better than nothing. So, being sedentary is sort of the worst thing you can do in a sense. But there's lots of data that's really come out recently that even 6 to 8 minutes of exercise a day really improves morbidity, mortality, and sort of risk reduction in chronic illness. And it can be sort of really that HIIT workout is really what we sort of talk about with really trying to get your heart rate up. And even for a short period of time can be really, really helpful. So it's really whatever speaks to you, but really making sure you get in that weight-bearing exercises to maintain that lean body mass.
Great, thank you. And another question came in. I noticed that men's risk of cancer is often higher than women's. What do you think attributes to this?
Yeah, that's a really good question. I think one of the things I had mentioned early in the presentation is that women carry a gene that can kind of protect them against certain cancers. So I think that's one thing. That's a really good question. I don't know if some of it is lifestyle, but there's probably definitely some sort of genetic component. But I don't really have a specific answer other than that.
Great, thank you. And next question. How can we use our BMI numbers to evaluate the ideal weight? Are there any other indexes that we can use as well?
Yeah, great question. That's a great question. So, these data are really based on the BMI, and I know that could also be skewed, and it might depend upon muscle mass, and it may not be as accurate. So, that is a really good question. I think that we're trying to find ways to really measure muscle mass or fat content more accurately, and I think that's always been a challenge in regards to really the accuracy of that testing. But really, unfortunately, these data were really just based on the BMI.
All right, great, thank you. And I believe that's all of the questions we have. We'll give everyone one more minute. Oh, we just got another.
Yes, more questions, please.
Does physical therapy for prevention of lymphedema? Yes, lymphedema help move the lymph system to prevent uterine breast cancer cells from reoccurring in the bones, brain, or lungs?
Oh, good question. So I don't believe I have any data to support that specific claim in terms of lymphatic massage or lymphedema in terms of prevention of cancer per se. It would make theoretical sense. And obviously moving the lymphatics manually, if it's not moving on its own because of surgery or other issues, is really, really important. We know that it decreases risk of infections, obviously range of motion and mobility and things like that. So it is really important to get on top of that, but I don't have specific data on actual prevention of cancer.
Great, thank you. And another question, do you recommend any specific pre or probiotic sources?
Yes, am I allowed to say like brand names on here? There's a couple that I have found, and it's just based on, so I guess I should say at least the qualifying factors should be, several different strains, and then I think it's greater than 40 billion CFUs, colony formulating units. So there's two that I like. One is called Complete Probiotic Platinum. They're both only available online. I'm sure you could sort of go to Vitamin Cottage or Natural Grocers or Whole Foods or somewhere like that and see if there's other ones that meet these criteria. But Complete Probiotic Platinum, and the second one is Stonehenge Dynamic Biotic. And those are because I've just researched it and found that they meet the criteria based on the studies. They both have prebiotics and probiotics. So it's a single capsule. The outside is a prebiotic that dissolves higher up in the digestive system. And then the middle part is the probiotic that then sort of feeds on the prebiotic lower in the intestine. And then the Stonehenge comes in a glass bottle because there's some data to support that glass bottles are really what you need because otherwise they just don't stay active. You don't need to buy a refrigerated version. They're not necessarily better. But I think the glass bottle having enough colony formulating units is important. The Probiotics Platinum comes in a plastic bottle, but it is like a dark blue, so it shields it from the light. Both seem to be proven to not activate until they hit your gut. So those are the ones that I use and that I recommend to my patients.
Good, awesome, really good to know. Another question here. My mother died of ovarian cancer at age 46. What kind of detection is available now that wasn't available before? She died in 1976.
Oh, gosh. Okay. That's a tricky question. So first, I would recommend that you talk to your gynecologist, obviously, and that you consider genetic testing, because if you have a family history of ovarian cancer, most likely you would qualify for genetic testing or counseling to assess your risk, which I think would be really important because then that would help guide the screening process. So, screening ultrasounds and CA-125s have not really been shown to be that great. When it comes to screening, we still do them, but they have not been necessarily borne out and proven. There is another test, a molecular test that seems to have a little more basis behind it, but it's really specifically for certain patients based on their risks. So kind of to talk to your gynecologist about that, but definitely, talk to her or him and really think about genetic testing to assess your risk, because that would then dictate what screening might be valuable for you.
Great, thank you. And next question, what are the main symptoms of lung cancer?
Yeah, good question. So there's several. Obviously, it can be anything from shortness of breath to pain with taking a deep breath. Cough is a big one. If you have any blood tinged, mucus, or what we call hemoptysis is a big one. So those are the things to look out for. For lung cancer, that would be localized to the lung. If something has spread or moved, then you may have symptoms based on the location of that.
Great, thank you. And it looks like we've covered all of our questions this evening. So friendly reminder, this webinar has been recorded and we'll be sending it out via email by the end of the week. Thank you again to UC Health for giving us the opportunity to learn more about women's health from Dr. Acharya. And thank you to all of those who joined us tonight. Our next virtual health event will be on Wednesday, March 8th on retirement and mental health. It'll be a great one. And we hope you have a great rest of your night. Thank you so much.
Thank you, Hannah. Have a good evening.